Welcome everybody. Today, Tony, Shane, and I will be talking about a comparison of McKenzie therapy with electrophysical agents for the treatment of work-related low back pain. Okay, so to highlight the study, like it was mentioned in this previous slide, this is a randomized control trial, and they're comparing a McKenzie therapy group versus an electrophysical agents group. It was a total of 271 patients were recruited that had chronic low back pain, and they were randomly assigned to either McKenzie therapy group or an electrophysical agents group. Both groups were treated for a span of 4 weeks, and the clinical outcomes, they were looking for pain intensity, trunk flexion, range of motion, and disability. At the conclusion of the study, it was shown that the McKenzie therapy was more effective in treating chronic low back pain compared to electrophysical agents. Now, for this study, the authors did not quantify the effect size, so we couldn't really report the magnitude of the difference between the McKenzie group and the electrophysical agents group. For the parameters of variability, the measurements that were used were the visual analog scale, the Oswestry low back pain disability questionnaire, and the fingertip to floor distance. And all of these outcome measures have been reported to be reliable. For the standardized protocol for these two procedures or for these two groups, both of them, like I mentioned before, lasted 4 weeks. The McKenzie group was assessed using the McKenzie methodology, and after 48 hours, they were reassessed just to confirm results that there was centralization of pain. If for some reason the patients demonstrated that there was no centralization of pain, they were recruited for another study and they were not included in this study. Each session lasted about 45 minutes. For the electrophysical agents group, each session lasted about 15 minutes, and they were treated with interferential current, ultrasound, and heat.
Continuing on the parameters of variability, there are no environmental interferences. These are the inclusion and exclusion criteria, which demonstrated homogeneity of the subjects. The threats of internal validity. There were 56 subjects who withdrew during the treatment, which was a 25.5% dropout rate, and intention to treat analysis was performed to reduce the effects of bias by the dropouts, protect the randomization of the assignments, therefore helped estimate the effect of allocating the McKenzie method into practice. Threats to experimental validity. The population was not representative because the subjects were recruited from a occupational health center.
Going over the strengths and weaknesses of the study, we know that it's a randomized control trial, meaning it's level 1B evidence. Has randomization and control, and the randomization appeared through patients randomly being allocated to treatment groups. We also show one of the strengths was a low rate of loss and follow-up, meaning almost all patients responded to a follow-up assessment and therefore adhering to the treatment protocol. Going into the weaknesses of the study, it wasn't double-blinded. Therapists knew what treatment methods they were using when administering it. Population was limited to the occupational center, meaning it's not generalized to multiple locations. Therapists were not McKenzie certified specialists. These PTs received only 10 sessions, 50 hours of training. So this means there's a possible decrease in reliability of performing the treatment. So going into the outcomes of the study, the claim of the study says there is a significance in McKenzie method in decreasing pain and decreasing disability. They also claim that the McKenzie method is more effective than electrical physical agent treatment method. So what does this mean as clinicians? Due to a high dropout rate over 25%, non-generalized data, and decreased reliability in treatment performance, the study shows that we need to take caution when attempting to apply the findings in this article.